Hey dog sport handlers, welcome to the Canine Handler Fitness Podcast. I'm your host, Liz Joyce, your go-to expert for all things dog sport fitness. Whether you're running agility, doing protection work, tackling search and rescue, handling a tough tugger, or just looking to build strength for a lifetime of adventures with your dog, remember, you are half the team, and I'm here to help you stay strong, mobile, and injury-free. Join me as I break down the unique demands of handler fitness, speed, strength, endurance, and everything you need to perform at your best, both in and after ring. Let's stay strong, stay in the game, and keep doing what we love. Let's dive in. Hey everyone, I am so excited about today's guest. She is a very busy woman. She runs 3 physiotherapy, osteopathic clinics in Australia and has taken it upon herself to educate other physiotherapists and fitness professionals, allied healthcare professionals about hypermobility. She truly is a leader in this field, and I brought her on because I have seen and met and worked with so many handlers that have issues with connective tissues. And the thing that I also find interesting is that it isn't as well known that when people have issues with their actual collagen development, the different ways that it can impact other areas of their life. And I'm hoping that today, in this conversation with her, some of those dots can get connected for you. Enjoy today's conversation, and I really appreciate you being here. Thanks so much. Welcome back to the show. I am so excited about today's guest. We have Dr. Ashton Wilson with us, and you are absolutely going to love this episode. Dr. Wilson is a true expert in hypermobility, and if you've ever wondered what that actually means, how it affects performance, pain, or even your dog's sport life, this is the episode for you. She brings a wealth of knowledge and a deep understanding of how our bodies move, stabilize, and adapt when the joints are a little extra. Ashton, I'm thrilled to have you here. Can you please kick things off by telling us a bit about yourself and how you came to specialize in hypermobility?
Wow, what an intro. Thank you so much for those really kind words. And it's great to be here. Thank you for having me on your show. I guess my interest in hypermobility came about when I discovered my own journey of hypermobility. And that really started about 5 years ago. And it all kicked off because I had a client who was really hypermobile. And she was a nurse. And at that time, it was the COVID pandemic time. So she was working really long hours on her feet. And she was just in so much pain, but she had to keep going. And I said to her, I'm going to research more into this and understand it better because I'm a little bit lost as to what to do with you. And then it was like the penny dropped for me. Looking into this research, I realized so much of what I was reading was how I was feeling. And I started to understand that hypermobility isn't just about joints being hypermobile and being double jointed, but it's actually a connective tissue disorder which can affect everywhere there is connective tissue in the body. So it just was like a mind-blowing moment for me that explained so much of my childhood pain that I experienced, so many of my injuries, so many unexplained connections that then all had a connection and an explanation. And it was one of those things where I thought, okay, well, surely there was something that I learned about this when I was at uni. And so I went through all of my uni lectures because I kept them all on my computer. I went through all of them, and there was one slide on EDS, and I studied for 8 years at university. So one slide, 8 years of study. And that's when I realized that us as health and fitness professionals, we just don't get taught what to look for when it comes to someone who moves too well. We are taught to look for restriction and what doesn't move, and that restriction equals pain. But when you're dealing with a hypermobile person, you're dealing with someone who moves too well, beyond end range, and they have pain. And so breaking that pattern and breaking that cycle of thinking is what I'm really passionate about now, is encouraging healthcare and fitness professionals to think a little bit outside the box and get a bit more creative with how they're working with their hypermobile clients.
Oh, I love that. Well, I'm really happy to see that you're here today, and I'm really excited for this conversation. And how I got to know Dr. Wilson is I had a client who was having a lot of issues. She has hypermobile Ehlers-Danlos syndrome, and I reached out to her clinic, and we've been working together to give me more tools to help this client work through the things that are going on with her. And one thing that I love about what you're doing and reaching out to people is that you're helping arm a bunch of people with tools to help their clients live better lives, because like you're saying, a connective tissue disorder goes way beyond having mobile joints and really gets into a lot of different symptoms, and we're going to get into all that stuff. And I'm hopeful we can start by talking about a diagnosis. And I know that diagnosing hypermobility can be tricky, and also with healthcare insurance in the United States, having sometimes an official diagnosis on your paperwork can present its own problems. But I know that you work with people by developing a working diagnosis. And I'm wondering, what kinds of screens do you put people through to help them or help you understand what kind of patient it is that you're working with?
Yeah, it's a great question. And it's one that I often get posed to me is, well, how do I diagnose this, or how do I work out if this is me? There are a few things we can do. So here in Australia, as an allied health professional, I can offer a working diagnosis to a client. Similar to what you said, there are processes in every country to get an official diagnosis. Here in Australia, it's seeing a general practitioner or a specialist to get that official HEDS or HSD diagnosis. But as an allied health professional, and for people working in the fitness industry, we can be really well equipped with the tools to be able to screen for these types of conditions and to give people a journey at the start of their journey. We can help them move in the right direction without the official diagnosis. So one of the common misconceptions is that you need an official diagnosis to start any kinds of treatment or management, and that's just not the case. You can start with a working diagnosis and start working on the systems that are effective for you, and also work on building strength and awareness throughout your body. So one of the things that we can use, so there are some really easy screening tools we can use to help indicate if someone does have joint hypermobility. That's usually what people will present to us with, is pain related to joint hypermobility. And when you're looking for a hypermobile joint, what you're looking for is something that moves well beyond its end range. So there is the Baton score or the Beighton score. I think in the US they pronounce it Beighton. The Baton score is a score out of 9 that measures joints across the body, but not all the joints. It's a very quick screen that you can use that measures the range of movement of the thumb, the pinky finger, the elbows, the knees, and the lower back. And out of that, if you get a score of 5 or above, you could consider that being generalized joint hypermobility. Now, the Baton score itself has quite a lot of limitations because we're dealing with, as I mentioned, only a few joints around the body to give an overall picture of generalized joint hypermobility. Now, I would be the first person to put my hand up and say that my most problematic joints are my shoulders, my wrists, and my hips, none of which are included in that screen, right? So the Baton score is something you can do that's a really quick screen to give you an indication if someone might be hypermobile, but it's not a diagnosis in itself. So it's an indicative score that helps us build a diagnosis, but it alone is not a diagnosis. So some people get quite disheartened when they see someone and they might be familiar with the Baton score. They do the score and maybe they score 4 out of 9, and that person then may feel invalidated, they may be dismissed, but it's really one test that helps us build the diagnosis. It's not the be-all and end-all. So other things you can look for are your historical questions. So I really like the historical screen. And what we do with the historical screen is ask a series of questions that help identify if the person in front of you has experienced joint hypermobility in the past. With the historical screen, we're looking for a history of being hypermobile. So you might ask the person, could they ever touch their hands flat on the floor with their legs straight, like bend forward, touch their hands flat on the floor? Could you ever do that in the past? Could you ever touch your thumb to your wrist? That's another question that you can ask. And if they answer yes, then you keep track of this as part of your historical screen. Then you can ask, did they ever consider themselves being double jointed? And so that, again, is part of the historical screen. And could you ever do the splits? You start to get an understanding of what that person grew up going through. Because as we get older, our tissue flexibility decreases. That's just a normal part of aging. The extensibility of our tissues decrease. We also go through hormonal changes, which can change our tissue flexibility. We can have multiple injuries occurring, which can cause restriction at certain joints, which can then limit that range of motion available, which is why the historical screen is really important. So when you are trying to come up with your diagnosis, you can test, debate and score, of course, but always do your historical screen and ask them about a history of being hypermobile. Then we want to screen for any comorbidities. And so that's where you have to have quite a good depth of what else is involved with hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder. And you start screening for all the systems in the body. This helps you formulate your full diagnosis.
I love that you bring up the comorbidities, because I think that is such a big part of what makes these conditions disabling. And while I understand that it has a genetic component, right?
Yeah, we believe that there is, yes.
And there isn't a medication to help with collagen, but you can treat the comorbidities. And that's what I understand someone would want to speak to their doctor about. And also, without a working diagnosis, that can be a hard conversation to have. So what kinds of things do you advise your patients to ask their doctors or medical teams? Like, what kinds of conversation starters do you have them have with their medical team?
Yeah, it's a great question, because like I mentioned, in 8 years of study, 2 degrees and a master's, there was one slide on EDS. And you know, the reality is that as a healthcare professional, to be a general practitioner or to be generally good at everything is very hard. There is a big wide world of conditions out there. And I think it's unfair to expect that everyone knows something about everything. It's just not realistic. We don't have that knowledge just sitting there waiting to pluck out of our brains. Like, a lot of the time, it does require additional research from your practitioner. So the best thing that I would recommend to people who are seeking help with their comorbidities or seeking more help with their joint hypermobility is to, first of all, find a practitioner who listens to you, someone who actually listens. And there is a real difference between someone who passively takes it in and someone who actively listens. Find someone who listens. Find someone who is open to working with you and open to trialing new things. Because, again, like I said, they probably don't have the knowledge. They probably don't know what POTS is or EDS is or MCAS. All these things are maybe not the kinds of knowledge that they have. But if they are open enough and they're curious enough, they'll be able to assist you in doing the research to find out what you need. So this is where coming into what I recommend to my clients, when you are working with a practitioner, come in prepared. So the first thing I often say to my clients is, let's get your history written down. So having a physical document there that's this is my medical history, this is what I've experienced, here's my paper. And it can be a personal recount of all of the things that have happened, you know, subluxations, dislocations, injuries, pain flares, you know, experiences of certain comorbidities like IBS or, you know, racing heart rates, things like that. Have it written down so that you don't have to recall something that may be traumatic, but also you've got all the information there so that your practitioner can then look through it later as well. Because we really want to be giving people the opportunity to research these kinds of conditions more. And if they have the information there, they can. So number one is bring your own medical history. Okay, then you can discuss your main points. So then once you go with that, you can look at bringing supporting documents. Now, this is where the EDS Society website is a fantastic resource, because they have lots of documents on there that you can actually give to your practitioner. So research papers and articles that you can give to say, this is what supports what I'm experiencing from a very well-renowned organization. So now not only do you have your personal recount, but you have evidence to back it up. And then if you're experiencing certain comorbidities that you feel that your practitioner isn't aware of, you can do certain questionnaires and tests yourself. So a great example is like the spider questionnaire to give them an idea of all the symptoms you're experiencing, or the MCAS questionnaire, which gives, practitioners an idea of the kinds of allergies and inflammations you're experiencing.
Now hold on, because this acronym stands for mast cell activation syndrome, and it's something I've been doing a bit of a deep dive on lately. Can you tell us just really quick, what is that?
Yeah, so look, to break it down as simple as possible, I'm going to do my best.
I know you will.
So when we talk about mast cell activation syndrome, which are part of our normal immune response, so mast cells aren't the villain here. They're not the bad guy. They're doing the best that they can to protect our body from foreign invaders like bacteria and viruses. That's what mast cells do. Except in mast cell activation, they are stimulated without that same level of threat. So for example, if you get a scratch on your skin or like a cut and it becomes red and a bit swollen, and then you get a little a scab forms, mast cells are part of that process. They come along, that initial process where it gets all red and inflamed, they come along and release histamines, they release cytokines and other inflammatory markers to inflame the area to stop any bacteria or any foreign bodies getting into the bloodstream. That's their job. However, when we have mast cell activation, every mast cell in the body is triggered by a cascade that is not a threat. So it may not even be a scratch on the skin. It could be, a cat licking your leg or something, or you've eaten some salami and now, the mast cells in your gut get activated, but then every mast cell in the body starts to be part of this cascade. And so it's almost like there's a mismatch in the response versus the actual threat. And that's when we end up with widespread symptoms related to the mast cells releasing these inflammatory markers. That's as basic as I can keep it.
That makes sense to me. We were talking a little bit, and one thing that the hypermobile clients that I work with have is a lot of pain. So we had talked previously about a pain toolkit or maybe a symptom management toolkit. Where can people figure out or learn what kinds of things they need to put in their symptom management or pain toolkit?
Yeah, look, the pain toolkit is something I talk about a lot with my clients. And the reason for that is because I want to empower them with the tools to be able to manage themselves, right?
That's right.
Because it can feel really overwhelming, and it can feel like a never-ending pit of problem after problem after problem. And pain is a big part of that. We're dealing with not only, the issues that come with joint hypermobility, where we are relying on joints being hyperextended to hold us upright, and all of the muscles working overtime to hold everything together. We have a number of reasons musculoskeletally why we have pain, but then we also understand that every comorbidity can contribute to that as well. So, having mast cell activation, that release of inflammation from a trigger, that can cause widespread problems. That can trigger a migraine or joint pain, all types of things like that. We can have other comorbidities like postural orthostatic tachycardia syndrome, so POTS, where a POTS flare can trigger, lightheadedness, dizziness, that nausea feeling, like a slow gut motility. There are lots of things that can be triggered when we have a flare-up of each individual comorbidity, which is why it's so important to understand what makes up your pie. So when I like to think of hypermobile EDS or hypermobile spectrum disorder, I like to think of it as being a pie and having multiple pieces that make up that pie. And everyone's pie is going to look different because everyone's going to have different slices of the pie. And some slices will be thicker than others because there will be some conditions that contribute more to that person's lived experience. So when I talk about the pain toolkit, it really is an individual experience because it's going to depend on what makes up your pie as to what goes into the toolkit. So typical ones that I would look for, let's say, for example, with joint pain, is having things to turn to that you can use to help better manage your joint pain in that moment. So things I like to empower my clients with are things like magnesium supplements. So magnesium supplements to ingest, so magnesium glycate typically is the one I recommend for muscle relaxation, or magnesium sprays on the skin. You know, all of these things can help with muscle relaxation. Epsom salt baths. These are good things to have in the toolkit if you don't have like a heat sensitivity and to get that global like pain relief. These are really good things to put in the kit, but it's going to depend on the person in front of you and what they can tolerate. So having things like massage balls in the toolkit, foam rollers, resistance bands so you can do your activation exercises to engage the muscles that should be working. Being able to turn to things like K-tape or rigid tape to help support a joint. Having things in the toolkits like braces and orthotics, things that you can turn to give your body a bit of a break. So building a toolkit really depends on the person in front of you and what they can handle, depending on their body and their presentation.
That makes a whole lot of sense to me. And I'm actually really happy that you brought up the idea of having braces or tape, because sometimes this condition can warrant people, using external things to help with stability. And I think you and I both are on the same page with this, where it's great to have an aid and you don't want to rely on it all the time. Can you tell me what kinds of things would justify someone using something like a knee brace? And also, if someone has Ehlers-Danlos or is hypermobile, will any brace do, or do they have to pick specific ones that are maybe more designed for that condition?
Yeah, look, I'm a big advocate for braces, tapes, mobility aids that improve quality of life. So anything that's going to improve someone's ability to do what they want to do, then we need to have that as part of the management strategy. So for example, like you mentioned with a knee brace, when would I recommend to someone to have a knee brace? Well, there's a number of reasons why a knee brace might be appropriate, but why we shouldn't just rely on it solely. So a knee brace can help stabilize the patella. So the patella is the kneecap. And if we have a kneecap that is subluxing or dislocates, or we have a knee that just loves to sit in hyperextension, we can use a knee brace to help support that joint. And the brace, the way braces work is they provide external feedback. So they provide like an external compression and external feedback. And what this does is it triggers this sensation in the body called proprioception. So our brain's ability to know where the knee is in space improves because there is something there physically touching it. That's why things like tapes work really well as well, because it helps the brain recognize where this area is in space and to improve our proprioceptive feedback to that so that we can be more aware of how to move it, more aware of what it's doing in space. So for example, I had a client a couple of years ago who was going on a big hiking trip through Italy, and about 8 weeks out had this just blown up knee. Didn't know how it came about. Typical hypermobile EDS things, right? Don't know how it started. I woke up like that one day and it was like a balloon. And so I worked with her and said, well, look, you've been training. This is just a speed bump in the road. Let's do all your rehab. Let's focus on strengthening what's going on around the knee so that everything else is strong. And then you're going to get a brace so that when you are hiking, you know that if your knee has a moment and it wants some attention, you can put the brace on and that gives you support. And she hiked for, I think, like 2 weeks straight. And she had that brace. At first she wore it a few days and then she didn't really wear it because she had done the work, but she had it there to turn to should she need it. And I think that that's the most important thing. We kind of, we have a bit of a stigma around certain mobility aids, like a crutch or a wheelchair or a walker. But at the end of the day, if it helps you do the thing you want to do and it gives you independence, then we should have it as part of the management strategy. And I think that that's where, you know, us in healthcare and fitness, we also need to have that awareness that we need to maintain what we've got. So maintain the strength that we have in the client, and that can look a variety of ways depending on what their pie looks like. And we need to support them with as many things that give them independence as possible. So I think that there is a place for all sorts of mobility aids, braces, tapes in the hypermobile world. We need to use it in conjunction with managing strength, maintaining our muscle mass, and working on our proprioception.
The thing that I'm loving about this conversation is there's so many shades of gray. You're not like, it has to be this way or it has to be that way, but hey, like, it's about finding a unique way through for each person. And I love your approach that way. And by the way, if this sounds like something that's going on with you, Ashton's clinic has a number of amazing practitioners that do virtual consultations, and they can help you work through all of this stuff. But listen, I got a question for you, because when people have these disorders, it can be very hard for them to activate muscles, to feel their muscles. They can do movements, but not often with the right muscles or at the right time. And also, I find that they have a really difficult time just telling where their body is in space, in the way of even being able to stand upright. So can you tell us a little bit about how these disorders affect tendons and ligaments, and how that affects a person's ability to be able to know where they are in space and use their body?
I think that this answer will be a twofold answer. So first of all, we'll start with body awareness and that term that I used before called proprioception. So proprioception is your body's ability to know where it is in space, as well as we have interoception, which is your awareness within your own body of what's going on. So proprioception, typically proprioceptive fibers are in our ligaments and our joint capsules. That's where they kind of sit, and they are like a nerve ending, right? So they're like part of our nervous system, and they typically sit around our joints and ligaments to help our brain know where those joints are in space. Now, when you have hypermobile tissue and you have collagen that is irregular, we have collagen and elastin that make up most of our connective tissue. In connective tissue disorders, collagen is irregular. So it means it doesn't act the way it should. It should be strong and stable, but when it's irregular, it acts more stretchy and it's got more give in it. That's why we have hypermobile joints. When we have tissues that move beyond end range at our joint level, what this means is in that feedback, that proprioceptive feedback from those ligaments and joint capsules sending back to the brain is like, there's like a disconnect. The brain doesn't quite know what's happening because it's moving further than what it should be. And so then that feeds into the body having a lack of awareness of what's moving, how do we use it, how did I get here, clumsiness, all of these things can be contributed to having decreased proprioception because those ligaments and capsules are more stretchy than they should be. So that's part one of the answer. Part two is, why do we have tightness in our tendons, in our IT band, in our muscles? Why are they so tight? Because often you'll hear hypermobile people will often have very tight muscles, but they'll have movement that doesn't quite match with the level of tightness they're reporting. Okay? What is happening here is we have, let's break it down, I'll try and make it simple. We have two parts of muscles in the body, the ones that perform power movement, so the ones that help us move, and the ones that help us stabilize. Now, when we have stabilizing muscles in a hypermobile person aren't in position to activate normally under gravity because our joints are more stretchy than what they should be. So we typically hyperextend them to stand. Standing is a great example. And then when we are hyperextended, the muscles that surround these joints that should be contributing to stability aren't in a position where they can. So they're either like on stretch or they're out of gravity's line and they don't engage because the joint's hyperextended, problem solved, we're standing upright. But what this means then is that the power muscles that are designed for movement are now contracting to help stabilize these joints, because the stability muscles, the smaller ones, the deeper ones, the ones closest to the joint, aren't in a position to do so. So the power muscles take over. So what we typically find is we have like a clenching effect kind of the glutes, of the quads, of that IT band, and we end up with this tension and this tightness because we have muscles that are designed for movement now also trying to contribute to stability. So they are working twice as hard. They are working overtime, and they're getting no help from the stability muscles. So when it comes to training body awareness and training movement, often getting more helpers is the way I like to frame it to people, is that I can see that you can squat, in a full range. That's great. But how did you get there, and what muscles are you using? So let's try and peel back the layers to have a better understanding of how we do a movement, how we control the full range of a movement, and how we can engage more stability muscles so that the power muscles can do what they're designed to do and our stability muscles contribute. And that, in the long run, is what changes that overall muscle tension, is having more helpers come to the party.
It's interesting when you're talking about stabilizing muscles, because the person that I originally came to talk to you about has pretty severe neck and upper trap pain. And one of the first things you had me do was work on her tongue strength, which I thought was really interesting. But it's really cool learning from you about how people's bodies will, we're adaptation machines, will make themselves do something, not necessarily always in the best way.
Yeah, our bodies are usually a series of compensations. So we compensate until a point that we can no longer, and that's when we end up in this kind of pain cycle. Because what we're asking the body to do in the way it has done so for so long, it can no longer sustain. So the recovery process overnight doesn't match the amount of demand that is required from those muscles throughout the day. And so we end up in a cycle where they can't recover, but they're still required to do the movement. And now we have really painful, aggravated muscles because they're just exhausted.
Yeah. Yes, that does make a lot of sense. So it sounds like if someone is suspicious, maybe if someone listening to this has kids that they think might be hypermobile, it sounds like the sooner someone can get on a physiotherapy plan, a muscle activation plan, to understand what's going on with them, the sooner the better. Would you agree with that?
Yeah, and I think with kids, we have to remember that kids are going to be more flexible anyway. We are born with more flexibility when we're young, but that doesn't mean that we need to dismiss if they are presenting signs of hypermobility. So I get approached by a lot of parents who are hypermobile themselves, and they are terrified that their children are going to end up the same way. And they, these are things we can detect earlier and start them exercising and doing fun things. Like kids should be able to play sports and do gymnastics and do all these things, but let's focus on making that really focused on the stability of the body and the control of their movements, even from a young age. So there are some amazing practitioners who work with children in this space. And I think that it is something that probably gets dismissed still, is the idea of being a child with HSD or HES, because the argument being that they haven't fully grown, they haven't gone through puberty, they haven't had hormonal things happen. And then we are born with more flexibility when we're younger. So I think it's identifying other signs. Flexibility as a child is pretty normal, but it's identifying other signs like clumsiness or joint dislocations. Joint dislocations as a child should be a big red flag that, hey, are we dealing with a child that has hypermobile tissue? If so, let's do something about it now to build those habits and keep them active for as long as they can be.
This is making me think about that medical history that you have people bring to their doctor. If someone listening to this thinks this might resonate with them and they're looking at their medical history, it would be good to go see someone who can really help you get a plan in place. Now, What kinds of things do you advise people look for when they're looking for a physiotherapist or a practitioner to help them work through the issues that come along with hypermobility? And as a practitioner yourself, what kinds of things should people be looking for in bios or in communication to help determine if the person that they're approaching is going to have the knowledge base to help them with this?
Yeah, it's a great question because, like I mentioned earlier, not everyone has this knowledge at the tip of their brain ready to pull out and give to someone. So first of all, there's a great resource on the EDS website, EDS Society website. It's a directory of practitioners who are registered on that website as being hypermobility knowledgeable. Like they have knowledge in EDS or HSD. And that's why you've registered to be part of this website, because it's a directory that is global as well. So if you go to that directory, you can find someone who's close to you who may not be the modality you're looking for. Maybe they're not a general practitioner. Maybe they're not a physiotherapist or a psychologist or whoever else you're looking for. They might be a dietitian and they have knowledge in this area. And that can still be a really great validating support, is to have someone in your corner who gets it, someone who understands what you're experiencing. Now, in saying that, sometimes there are, I would say, more practitioners in a higher density in bigger cities. So that's where working with someone online can be a really great option. Now, you've mentioned it a few times. I do online consulting from my clinic, and what I've found has worked really well is when I work with a client online is to actually communicate with a practitioner that's close to them, that they trust. So maybe it's a massage therapist, maybe it's their personal trainer, maybe it's a chiropractor, whoever it is. I communicate with them and say, hey, I'm working with this person online for X, Y, Z. These are the things I'd like you to look out for. Can you report back to me what you find? And then creating that communication channel, if that person is open enough to working with you, you actually get really great results for the client. The practitioner on the other end learns quite a bit about what's going on, so they can actually be a really good in-person port of call for you, as well as just having that support system around you. And in a way, working online gives me the freedom to be part of the support system, no matter where it is around the world. So for people who are, because I often get messages and comments on my social media content saying, I'll post something about EDS or being hypermobile or whatever. And people often comment saying, that's great, but there's no one in my area who can help. What am I supposed to do? And in that case, I would suggest the EDS Society directory is a great starting point, but also working with someone online in an online capacity and then working in conjunction with someone close to you can be a really great way to take steps forward, because there are so many of us who know more about this, but we are all scattered around the world. So sometimes it means working with someone in an online capacity and then being able to take that, utilize that session and the advice and the exercises given, and then see the person that you're working with in person and communicate that as well. And then you can have a different goal with them. So that was a really long-winded explanation of who to see, but that would be my recommendation. You start with the EDS directory and then look for online options if that's not suited for you.
I think that was a perfect length of answer, because people need to hear all of that stuff. And also, if you go see someone who's a personal trainer or a physiotherapist that you think might be able to help you, it's okay if they can't and you need to move on to the next person. Finding people in this space to really care for you is going to take a little bit of trial and error. Would you agree with that?
Oh, yeah, for sure. Because not everyone is going to vibe with the person in front of them. Finding the person that fits for you is really important, and doing what is going to serve you, because I think there can be times where people who are living with these kind of complex conditions, they get lost in the system because they're working with people who aren't listening to them, who don't have their priorities at the center of the treatment plan. And maybe they're a bit dismissive of EDS, HSD, then that's not the right person for you. If they're not willing to be open-minded and they're not willing to listen to you, then they're not the right person. You can find someone else, and that is okay. Not everyone is the right fit for everyone.
It's like doctor dating.
A little bit. But if you want to find someone, even when it comes to the idea of doctor dating, the idea is to find someone you connect with and someone you trust, right?
Yeah.
If you're dating someone, you want to be able to connect and trust.
Of course.
And the same comes when it goes to the healthcare team, is that you want people in your corner, people who go, I get it. What you're going through, that sucks. Let's do something about it. Not the person who gaslights you, not the person who makes you feel like you're crazy or you're making it up. So finding the people who get it and find that person you connect with that you trust, even if they don't know everything about hypermobility. Like, I think about what an amazing person you are, Liz, for reaching out to me and saying, hey, can we just have a session because I've got a client I really want some help with. And that in itself it just shows the kind of person you are, that you go above and beyond for your clients. So to the listeners, find people like that who are willing to go above and beyond for you too.
Oh, that's so nice. Thanks.
You're welcome.
And I also want to share that I have a complex medical condition, and I thought I had the best doctors. I just recently moved provinces last year, and I had what I thought was the best medical team possible. I moved provinces and had to change that whole medical team. And you know what I found as I walked into my GI's office, and he asked me about some fallout of a surgery that I had that no other doctor that I'd spoken with had brought up or was really willing to discuss, but he knew about it already. And just walking into the appointment and having him bring it up himself made such a big difference in me being comfortable in that situation, and also me having faith that he was going to be able to help me, and he has, and it's been amazing. So I think sometimes, like doctor dating, you are going to find those people that you just really click with, and it's just the best. So keep looking.
Absolutely.
We have been talking a little bit about patients needing to put in the work. And when I hear you say that, I think about patients needing to do activation exercises, regular stretching and releasing of tight muscles and fascia, and also strengthening exercises, as well as keeping track of the triggers that maybe would cause problems with the comorbidities. And can you tell us, am I on the right track with that? And can you talk about what, the work looks like and why it's so important for people when they're thinking about managing their hypermobility?
Yeah, and I think I will be sensitive in the way that I speak about this, because I understand that every person who's living with HEDS or HSD is going to be at a different level of capacity, and I respect that. So when I say do the work, what I mean is that there is no cure for this condition. There is no cure. But there are lots of great management strategies that are available to improve your quality of life that are within your reach. Now, we mentioned earlier, when you have a number of comorbidities contributing to your pie or your pain picture, it does mean addressing each of those individually, but they do need to be addressed. And that comes down to you doing the work to address them. So, for example, if you have MCAS, so mast cell activation, and you know that one of your triggers is apples, but you insist on having an apple pie every day, well, that's a little bit on you for not taking the triggers seriously. Okay, so when we talk about these things, like we're all human, and most of us who are seeking this kind of help are grown adults. And so if we're a grown adult, we're making our own decisions, and that's okay. We're allowed to eat the apple pie if we want to, but that's understanding that what are the consequences to doing that thing. So when I say do the work, I mean do what it takes to manage your body the best that you can, and that means you doing your part. So as a practitioner, I can offer advice and education and exercise, and I often write exercise programs for my clients for them to follow themselves so that they can do a program where they can progress and build strength and awareness and all these things. But if they don't do that program, then nothing's going to change. You can't wish it better. You have to do it. And that's what I mean by doing the work. If you have the things to do, if you're seeking the kind of help from a professional because you are in pain and you are experiencing all sorts of symptoms, then what they give you, you have to actually do it. And that can be hard as well, because a lot of people are experiencing chronic pain, maybe they've got some chronic fatigue on top of that. It can be hard, but it means making that commitment to your body and finding the balance of what works for you. So if that means doing a 2-minute commitment of movement per day, then that's what it is. That's where we start. You find your starting point and you commit to it, because your commitment to your body is your investment. Okay, so if you think about brushing your teeth, why do we brush our teeth? Well, it's to prevent cavities, right? If we do our daily movements every day, our daily joint activations, our daily postural training, our daily limiting of our food triggers, or taking our daily electrolytes, these things are to manage our body and to prevent those massive flare-ups that can occur with HEDS and HSD. So when I say do the work, I mean do what has been recommended to you, because that's your end of the deal, is to do what's been asked.
That's great. There's a lot that's so empowering on all of that. I know that when people have chronic pain, it can really affect their mood and mental health. And I think when people have their mood and mental health affected by living in a body that's causing them a lot of pain, staying motivated can be very challenging. Do you have a couple of strategies? What kinds of things do you do to help your clients get refocused and dig into the work at whatever capacity that is for them?
Yeah, so obviously we're dealing with a complex condition that it's a multifaceted condition, and mental health is a big part of that. So experiencing feelings of depression and anxiety are a really big part of living with a chronic condition. So the first thing I would always say to anyone who's experiencing these feelings is work with a psychologist, work with a counselor, find solutions to help you understand why you feel that way. That's the first thing. When it comes to motivation is a tricky one, because it's kind of like momentum in a way. What helps roll the big rock down the hill? It's that initial push, yeah? And then it just keeps rolling and it becomes easy. Motivation has to start from within the person wanting to do something that is greater than just their pain. Because pain as well is a feeling, and it's an individual feeling, an individual experience. Everyone's pain is going to be different. So we need something bigger than that to help people start pushing that rock down the hill. So usually what I'll work with is a person's goal. What drives them? What's going to help them commit to doing this thing? And it's, it would be the same in the fitness industry as saying, I just want to lose weight. Well, why? Why is the reason that you're here? Because if someone wants to start working with me because they're in a lot of pain, that's okay, and I'm here for that, and I'm here to help you. But I need to know why and what it is that you want to change, that it goes beyond your pain, because I can't guarantee that will change. I don't know how long it will take. Everyone's pain is different. But if it's something that means something to you, for example, I remember working with a girl online who was a police officer, and she couldn't stand in the kitchen to cut her vegetables. And her goal was, I want to be able to cut vegetables to help my husband cook dinner. I said, okay, so first thing we need to do there is we need to learn how to stand and be able to stand for, at least 10 minutes. And then we need to build the strength in your wrist to be able to cut and to use a knife. And so we looked at, different ways of how we could achieve that goal. And once we knew that that's what she wanted to achieve, she had other comorbidities that were contributing, like a bit of unmanaged POTS that was making her standing really difficult. We worked on each of those things, and then that's what we worked towards, standing in the kitchen to cut vegetables for 10 minutes. And then when she could do that, I said, great, now you've ticked that off. What's the next thing? Well, the next thing was, she wanted to be able to go on a hiking trip with her husband. Great. Then now let's work towards that. And so if you know what it is in your heart that makes you want to change, then you will change it. But if you're doing it because someone else says you should, or because you just want a quick fix, or you want something to help the pain straight away, then, you know, you're probably going to be a bit disappointed, because working with this kind of condition, it takes time, it takes commitment, but things can improve. And it's not to say there won't be speed bumps along the way. There often is. There's often an injury or a setback, but it's never a straight line. You've got to think about it as being that up and down journey, but we're heading in the right direction. So long as you know what you're working towards, then we can continue to put the steps in place to get there. So that's usually how I work with motivation. It has to be something deeper than just, I want to have no pain. So once we know what they're working towards, we can work towards it together.
I love that the first goal you brought up was cutting vegetables in the kitchen. That's where people start sometimes.
And that's okay. Whatever the starting point is, you know, I'm here for it. We're all here for it. It's just working with what you want to do. You know, you can say, I want to run a marathon. That's great. But can you run 200 meters? Because that's the first step. You know, to get you to run means you have to be able to walk. Can you walk? Okay, let's start working towards that. And again, saying that in respect to certain cases where running may not be quite possible. So let's work with what is possible and what's realistic for the person and what means something to them.
I want to ask you about pain management. If someone doesn't have hypermobility disorder, it's not uncommon for them to approach a physiotherapist and get dry needling or go for massage. And also, if people develop osteoarthritis in the joints, also not uncommon for them to pursue hyaluronic acid injections or PRP. In someone living with a hypermobile body, do you advise those types of interventions?
Yeah, I think anything that can help manage pain is a good intervention, but it needs to be used in conjunction with longer term management strategies. So all of those interventions that you mentioned there, they are all good pain modulators. So those interventions can help with the sensation of pain in that moment, and that's great because it gives us an opportunity to get back to doing our exercises or our activities of daily life, all of those things. But as a standalone, there is no magical fix. There is no injection that will change this. There is no amount of massage or amount of dry needling that can change what your body is experiencing day to day. It can help with pain modulation, which is great, and I do recommend that. But ultimately, we need to combine that with active interventions. So active exercise rehab, active management strategies for other comorbidities.
Slice that pie up and eat it, right?
That's it. One slice at a time.
I have one last question for you, and it's about perimenopause and these wonderful hormones that we live with. Are there special considerations or things that you account for when someone's entering perimenopause, or as I've heard it recently called cougar puberty? And I'm here for that. Do you treat those patients differently?
So it's something I'm really interested in at the moment, and my colleague here and I are doing quite a lot of research into this area ourselves. But perimenopause, I think for born females, perimenopause is something that we just don't talk about. And it's something we should know more about, because 50% of our population are born female and will go through perimenopause and then reach menopause. It's the reality. So understanding what kind of changes happen during this time. So obviously we have hormonal changes, right? Because we're not releasing our eggs from our ovaries, which is contributing to the hormones that we're releasing, because we know the ovaries have a big part in releasing things like estrogen. Now, interestingly, our tissues all through our body have estrogen receptors. So when we are producing less estrogen, there's less estrogen circulating to bind to these receptors, which can then mean tissues become stiffer. and more tight. And this is often something I see reported in clients that we see here, is that women will present with, a real like stiffness of their neck. The neck is often the one that it happens in. They'll have this stiffness, this tightness, this pain, and they just can't move their neck. And then they'll often come into the clinic and passively, if we hold their neck, their range is full range. But actively, the muscles are so tight that they cannot move their neck.
Wow.
And then this is where I often ask them, when was the last time you had a regular period? And they'll often say, probably 9-10 months ago. I'm like, okay, so we may be going through perimenopause. Have you spoken to your doctor about it? And then that's when you can start that conversation of saying, well, hormones actually affect your tissue flexibility. So it's something worth discussing to see, can we look at like a hormone replacement therapy to help you manage this? Because I think that we need to normalize HRT for women.
There is an army of women out there working on normalizing this, and I'm so grateful to them, including
yes,
you.
Me too.
I know. Well, hey, thank you so much for being here today and sharing all of this information with us. I really appreciate your time and your expertise, and this was really great.
Yeah, thank you so much for having me, Liz. It's been great to chat with you, and thank you to all the listeners for tuning in.
Yeah, thank you so much. And Ashton, I will link all of the ways to get a hold of you and the Ehlers-Danlos information, the society information in the episode notes, and I'll see you around Calgary for a hike pretty soon.
Oh yeah, I can't wait.
I know, me too. All right, thanks again.
Thank you.
Thanks so much for being here with me today and choosing to spend this time investing in yourself. I hope you feel encouraged to take action. Even the smallest steps forward will add up in ways you cannot even imagine yet. If this episode gave you something to think about or lifted you up, please share it with a friend. You really never know who might need these tools today. For more information, practical tools, and resources to help you get stronger and confident both in and out of the ring, head on over to caninehandlerfitness.com. You can also find me on all the socials under the same name, so come on over and say hi. I'm here to help you build the skills, knowledge, and belief you need to reach your goals. Keep going, keep learning, and most of all, keep showing up for yourself. You've got this, and I'll be here cheering for you every step of the way.